we're now able to use the first-line osimertinib in Japan too. So after the approval for the first line, we really go to the osimertinib as the first-line treatment because of toxicity, because of CNS activity. Of course, it's very difficult whether there is a benefit in sequential treatment, such as like afatinib to the osimertinib. However, because of the toxicity and CNS activity, as I already have said, we just tend to use osimertinib as the first-line treatment. In Japan, we still try to use the platinum doublet with the pemetrexed. There is emerging data with carboplatin, paclitaxel, bevacizumab, and atezolizumab. We're now just finding whether that treatment is really comfortable with Japanese patients. However, there is always the argument that the PD-L1 inhibitors are really doing well or not to the patients with EGFR mutations. So we're just kind of really step by step to assess whether they are really good. However, of course, there is a chance for those patients to take a PD-L1 too. But in Japan right now, we still use the pemetrexed and other carboplatin or cisplatin as the second-line treatment. As for the ALK translocation patients, in Japan, we are long using the alectinib, the first-line treatment. We have developed the alectinib in Japan. We lead the trials of the JALEX trial, and also it was kind of replicated with the ALEX trial in the global study. But we are really lucky that we have early access to alectinib, so we have many experience in alectinib. We don't know whether really alectinib first line is really superior to other treatment in the terms of the efficacy. However, the toxicity of the alectinib is kind of really a miracle that we can prescribe as the treatment of the hypertension or something like that. So I think that drug is really, really doing well to the patients with the ALK translocation. So we first try alectinib, okay? As for the ROS1 in Japan, we still can only use the crizotinib. But fortunately, we are kind of accustomed to use the crizotinib because there was some time that the only crizotinib was the treatment for the patients with ALK translocation. So we have some experience for that. So even though the patients with ROS1 is really, really small, when we found that, we are kind of confident that we can prescribe crizotinib really and manage the toxicity so that the patient can really benefit from the use of the crizotinib. As for other mutations, we do BRAF testing. And in Japan, we believe from next year, from the 2019, we are trying to reimburse all the next generation sequence system, for example, target sequences to all the cancer patients. We're trying to do that kind of system, trying to make those kind of systems. So right now, we only have access to BRAF, but after that, I think we'll have MET14 skipping or the HER2. We always have lots of investigational drug for that, and we already have some experience that is working well. So we believe that after the reimbursement by the universal healthcare system in Japan, I think the patients with those kind of uncommon mutation will really rise. So after that, we believe that many patients can go just directly to those kind of treatment after the NGS testing. Yeah, red fusion, we also have the, I think Loxo is really kind of promising drug. But in Japan, we have just started phase 1. So right now, there's lots of patients waiting for Loxo. So I believe the study goes well. And I believe we will have access to any kind of RET inhibitor as soon as possible. The second-line treatment after the EGFR TKI is, of course, the pemetrexed with platinum. However, in Japan, and then I think in many countries, there is a lot of elderly that will suffer from the EGFR mutation lung cancer. In those patients, it's very difficult because we started from the EGFR TKI. They're really doing well. And I think most of the patients using EGFR TKI in the elderly is usually was given best supportive care before the emergence of the EGFR TKI. So after the relapse of the EGFR TKI, now we have to think about it. She or he have already experienced EGFR TKI. She was doing well even with lung cancer, but he's over 80, over 85. Shall we give the platinum doublet? Oh, that's too difficult. Then maybe we should give the pemetrexed. But of course, they kind of just not like to take those kind of drugs, but we really have to think about the toxicity and really clinical benefit to those kind of patients. And there's no evidence. I think it is very difficult to make evidence in the elderly or the low performance status, but we really have to kind of challenge every day for those kind of patients. Of course, we're waiting for the approval for the triplet regimen with the platinum doublet with pembrolizumab, atezolizumab, or anything, and also for the PD-1s. However, we also have concern that after combination therapy has really prevailed, it's really difficult for us to find the biomarkers, which means that if you give it once, of course, some patients will benefit. That's true. However, some patients, maybe less is better or less is enough. But it's very difficult to find when we give all at once and then find a biomarker here. So I think it's really challenge for us how we can kind of course, make progress to patients with lots of drugs. However, we have to really think how we can go back so that we gonna not make the patients demerit, but give the less toxicity. I think that's the next question we always have to think of.